Mabuhay! Welcome to Class 1999's webinar series. Maraming salamat po sa inyong pagdalo. We would also like to thank Class 98 for allowing us to start implementing our homecoming activities 1 year before our Silver Jubilee year in 2024. I hope you will learn a lot from our webinar series and participate in the succeeding events that Class 99 will sponsor leading up to our homecoming in December 2024. Mabuhay po tayong lahat.
As we gather for this webinar, which is part of the UPCM Class of 1999 webinar series, let us acknowledge the source of all wisdom and the creator of life. In the name of the Father, and of the Son, and of the Holy Spirit, amen. Our Father, we come to you grateful for this opportunity to expand our knowledge of the many wonders that you have imbued in the human body. Grant us knowledge and understanding so that we may better use our intelligence to bring healing and comfort to our brothers and sisters who are ill. Grant us humility to treat our patients with compassion and love. We pray also for our presenters. May they share with us their expertise with confidence and kindness. We ask all this through your Son, the Divine Physician, Jesus Christ our Lord. Amen. Sa ngalan ng Ama at ng Anak at ng Espiritu Santo. Amen.
We would like to ask everyone to kindly turn off your microphone and video. Please type your questions in the Q&A chat box. We will try to address all of them in the open forum after the presentation. Evaluation and post-test questions will be available for 1 hour after the initial broadcast. A certificate of attendance will be emailed to you once the evaluation and post-test are completed.
Good afternoon, everyone. I am Dr. Elizel Lagunzat Claveria of the University of the Philippines College of Medicine, class of 1999. I am an ophthalmologist and the chair of the Department of Ophthalmology of Medical Center IMOS. I am here on behalf of the UP Med Webinars team of the class of 1999 to moderate today's webinar. Our topic is about reducing the renal and cardiovascular complications of diabetes. Before we introduce the speaker, we would like to remind the audience that you can type in your questions in the Q&A box even while the lecture is still ongoing. For today's webinar, we are privileged to have a distinguished alumna of the UP College of Medicine from the class of 1999. Dr. Mia Fojas had her residency in internal medicine and fellowship in endocrinology, diabetes, and metabolism at the University of the Philippines, Philippine General Hospital. She is the immediate past president of the Philippine Association for the Study of Overweight and Obesity, and is a past president of the Philippine College of Endocrinology, Diabetes, and Metabolism. Dr. Fojas is an incumbent member of the Board of Directors of the Philippine Lipid and Atherosclerosis Society and is a senior lecturer at the Department of Biochemistry and Molecular Biology of the University of the Philippines College of Medicine. Ladies and gentlemen, we are proud and honored to welcome Dr. Mia C. Fojas of the UP College of Medicine class of 1999.
introduction, Dr. Lagunsad, and I'd like to thank AstraZeneca and UP College of Medicine Class 99 for having me in this webinar. Now, let me share you my slide. So today I was tasked to discuss about raising the standard of care beyond glycemic control. So you will see slides on diabetes, heart failure, and kidney disease. You can see in this first slide that the diabetes burden in the Philippines has been increasing through the years, but these are just predictions based on the Diabetes Atlas several years ago. And for those individuals at 20 to 79 years old, it was predicted that by 2021, there will be the prevalence of diabetes will be 7.1%. Unfortunately, based on the FNRI data of adults, last 2019, the prevalence has been at 8.2% already. So we have surpassed the prediction of 8.2% by 2045. And as of 2022 February, 2023 February, diabetes has remained the fourth leading cause of death in the Philippines. So you can see that there. It was previously COVID-19, but diabetes is back. Now, persons with diabetes most often die because of the complications, and heart failure and chronic kidney disease are the most frequent complications of type 2 diabetes. And it is predicted that about 50% of patients with diabetes will develop heart failure, and 58% of them would also develop chronic kidney disease. So it is actually a very vicious cycle. One causes or worsens the other. Let us take a look at the typical patient of ours, Sander. He's a 50-year-old male. His blood pressure is at 135/80 on losartan 50 milligrams once daily, and his A1C is at 8.5%. He's a newly diagnosed type 2 diabetic or person with diabetes. His serum creatinine is at 1. UACR or urinary albumin to creatinine ratio is 250. It's high. GFR is at 81. His body mass index is 30. He's about 5'9", so he's about 93 kilos. And he has dyslipidemia. As you can see, the LDL is 2.8. His risk for chronic kidney disease is up to 40%. And his risk for heart failure is about 50% based on current statistics. Now, how should we treat Sander for his type 2 diabetes? This slide shows you the current clinical practice guideline from the American Diabetes Association. And you have 3 goals in the treatment of type 2 diabetes. The first would be glycemic lowering. Second would be cardiorenal risk reduction. And third would be weight management. I know this is a busy slide, but let us take a look at this part of the guideline first, the one on the end. That's third part. 1, 2, 3. So that there you can see the goal number 1, effective glycemic management. First, let's take a look at this part. Okay. The current approach to type 2 diabetes is easier now. It used to be just metformin at first with lifestyle modification, but right now we encourage early combination therapy, because the earlier that you control the blood glucose of your patients, the better, and the lower probability for them to have complications later on in life. Now, for the second box, you can take a look at this. This shows the efficacy of currently available anti-hyperglycemic agents. And of course, the higher efficacy would be your insulin and your other injectables. But for those with high efficacy versus the very high efficacy would be the other GLP-1 receptor agonists, the injectable ones, metformin, SGLT2 inhibitors, sulfonylureas, and thiazolidinediones. So SGLT2 inhibitors here, you can see, have higher efficacy for glucose lowering compared to the DPP4 inhibitors. This slide shows you why it has a higher efficacy than DPP-4 inhibitors. And you can see that in this forest plot, these are the DPP-4 inhibitors versus the SGLT2 inhibitors, and these are the randomized controlled trials. The change in A1C is higher for the SGLT2 inhibitors versus the DPP-4. And this slide shows you that data, at least for dapagliflozin. Dapagliflozin with metformin versus a DPP-4 with metformin, that in 24 weeks, patients decreased their A1C by 2.1% versus only 1.4% for those on DPP-4 inhibitors. Likewise, it's the same case with the fasting plasma glucose and with the postprandial glucose. So you can see here that dapagliflozin can actually decrease your A1C by 2.1% versus other SGLT2 inhibitors in combination with metformin. That would be about 1.9%. Or other SGLT2s with DPP-4 that would cause an A1C reduction of 1% and versus the DPP-4 inhibitors alone at 1.4%. Now let's take a look at Sander. So his baseline A1C was at 8.5%. And if you actually start him already on dapagliflozin with metformin, you expect around 2.1% A1C reduction. So if your target glucose is less than 7% or even less than 6.5%, you have already reached that target at least in 12 to 24 weeks. Now, however, you can see here the body mass index for Sander. It's about 30 or about 93 kilos for the weight. Can SGLT2 inhibitors actually address this weight for Sander? Here you can see that again in the clinical practice guideline. Intermediate effects on weight would be your GLP-1 receptor agonist. That's excluding the very high efficacy of the other injectables here, and the SGLT2 inhibitor. So it has intermediate efficacy for weight loss. And how much weight are we talking about here? When you compare dapagliflozin with metformin versus metformin alone, you expect a 3.3 kilogram drop in the weight, at least for these type 2 patients with type 2 diabetes. And on the side, you also lose a little bit of the systolic blood pressure. Nagde-decrease siya by about 5 millimeter mercury versus placebo. So again, you can see the 3.3 kilogram weight reduction versus placebo, but there was another study of dapagliflozin versus other SGLT2 inhibitors, and the weight reduction there was 2.9 kilos versus 2.08 for other SGLT2 inhibitors. Of course, DPP-4 inhibitors do not claim naman the weight reduction. They are actually weight neutral. So again, no weight reduction for those who do not really need to lose weight for our patients with diabetes. Going back to Sander, his weight was 93 kilos, so he will be actually about 90 kilos with a treatment of dapagliflozin with metformin. Still not within the ideal BMI, but he is still a work in progress because he's a newly diagnosed case. They still have to guide him with regard to weight management. Now that we have quite achieved the first two goals, our glycemic control and weight reduction enough to protect our patients with diabetes from future complications. Based on current data, among patients with type 2 diabetes, heart failure and chronic kidney disease are consistently the most frequent complications. And this is global data. You have your cardiorenal disease in England, Germany, Japan, it's all over the place. So that's cardiorenal disease, and then followed by stroke, MIs, and then peripheral arterial disease. But those are really high. Now, based on these cohort of persons with diabetes studies, again, glucose control would not be enough to reduce the risk for heart failure and mortality. You can see that in this forest plot. And again, despite good glucose control, more than 50% can actually, 50% of persons with diabetes can actually develop microvascular disease after the diagnosis. So as for the burden of chronic kidney disease in type 2 diabetes, you can see here in this slide that lower eGFR and higher albuminuria independently predict mortality. But if you add on type 2 diabetes to the equation, type 2 diabetes can actually significantly increase the risk for mortality. Diabetic patients are in the blue dots here. For our local data, more than 7 million Filipinos have chronic kidney disease, and this is as of 2021. We had the Philippine Renal Disease Registry, and they have data until 2016. And based on statistics, the predicted prevalence would be higher for the subsequent years from 2016 onwards. After all, halos logarithmic ang pag-increase niya, incidence and prevalence of kidney failure. Now, the leading cause for kidney failure remains to be diabetes, and this has been so since year 2003. If we take a look at the data from the PhilHealth claims, as of 2022, the dialysis rate has significantly increased by 400% in the past decade, and this accounts for the highest claims in PhilHealth at 17 billion pesos in 2022, and this is 21.43% higher than the previous years. Moving on, can dapagliflozin prevent chronic kidney disease? So now again, we go back to the clinical practice guidelines. This is goal number 2 in the Trinity, and this is cardiorenal risk reduction. Indicators for high risk would be defined as those who are 55 years old and above with 2 or more additional risk factors that would include obesity, hypertension, smoking, dyslipidemia, or albuminuria. This is a new category. These are the multiple risk factor patients, and kasama dyan si Sander, who's known to be hypertensive, dyslipidemic, and with albuminuria. However, 50 years old lang siya, if I remember correctly. Yeah, however, 50, but he still has multiple risk factors. Now, taking a look at the different cardiovascular outcome trials for SGLT2 inhibitors, you have your empagliflozin, canagliflozin, and dapagliflozin in this slide. And DECLARE, that's the one for dapagliflozin, is the longest and largest and broadest cardiovascular outcome trial, which recruited persons with diabetes with and without established ASCVD or atherosclerotic cardiovascular disease for early prevention. And these are the patients that you commonly see every day. So you can see that in EMPA-REG, more than 99% of the patients that they recruited already had atherosclerotic cardiovascular disease. Whereas for the DECLARE, 59.4% had multiple risk factors, and 40.6% have atherosclerotic cardiovascular disease. So it's a mix of the patients that we actually encounter in our clinics. For the DECLARE trial, dapagliflozin demonstrated a significant reduction in the occurrence of the renal specific outcome, which is a decrease in the GFR or creatinine clearance by about 40% or more, or a decline in the GFR of less than 60. So 47% relative risk reduction, and there's 24% relative risk reduction in the cardiorenal composite endpoints, which combines a renal specific endpoint and your cardiovascular death. And in this slide, dapagliflozin shows here that it not only prevented deterioration of kidney function, but also improved albumin excretion. Going back to Sander, his UACR was at 250 milligrams per gram. So his he has albuminuria, and you expect that with dapagliflozin, there's a 47% CKD risk reduction for the patients such like Sander. Now we talked about the prevention of chronic kidney disease. Can it actually treat chronic kidney disease? And yes, there is an RCT for that, and they have the DAPA-CKD trial. This is the first SGLT2 inhibitor for patients with chronic kidney disease with and without type 2 diabetes. So you can see that they enrolled individuals. 68% of the population had type 2 diabetes, and 32 did not have any diabetes, but the eGFR ranged from 25 to 75, and all of them had albuminuria. They were already on a stable dose of ACE or ARBs for more than or equal to 4 weeks. For the composite sustained more than or equal to 50% eGFR decline, and those are the primary endpoints. There was a 39% relative risk reduction. All-cause mortality decreased by 31%. So this trial, the DAPA-CKD trial, was stopped early due to its overwhelming efficacy, and it's the first study that would show renal outcomes that would have robust benefits on all-cause mortality among patients with or without type 2 diabetes. So for the results of the DAPA-CKD trial, for all patients, for the primary composite outcome, all patients, there was a 39% relative risk reduction for the cardiorenal endpoint and mortality. And for those with type 2 diabetes, it was a 36% relative risk reduction. For all-cause mortality, it was 26% for patients with diabetes, but for all individuals with or without diabetes, it was a 31%. And kidney transplant and dialysis was prevented in 34% of cases. So here, dapagliflozin also delayed the progression of the eGFR decline. You can see that this is the dapagliflozin, that's the one in the red line. You can see that for the first about first 2 months, the GFR, the creatinine clearance, can actually decline a bit. This is what is often referred to as the GFR dip, and it is the same response pattern that is seen among those with ACE inhibitors and ARBs, but later on they actually improve in creatinine clearance. And you can see here that by 1 year versus those on placebo, GFR actually unites in a year's time, and later on GFR creatinine clearance actually improved. Okay, so you can see that versus placebo. Here is the trend of the eGFR in the DAPA-CKD trial. Remember that these individuals already had deranged kidney function, and the mean age was actually 62 years in the study. And remember, there is such a thing as an age-related decline in the creatinine clearance of about 1 ml per minute per year, or 0.8 to 1 after the age 40. So that's on top of the GFR that at baseline that already was deranged, or they had albuminuria. You can see that in the earlier slide that the GFR actually improved for those with on dapagliflozin. And if we connect the dots or continue the line for several years, creatinine clearance, you see that dapagliflozin could actually delay dialysis by 9 years. So moving on, only dapagliflozin among all SGLT2 inhibitors provides prevention of new or worsening nephropathy and reduction of mortality among persons with diabetes. You can see that in the DAPA-CKD trial. Now, after the chronic kidney disease, can DAPA or SGLT2s prevent heart failure? Here is a study that showed that 68% of patients already had some evidence of asymptomatic LV dysfunction about 5 years after the diagnosis of type 2 diabetes. This is normal LV function, and this is about 68%. There's diastolic dysfunction, systolic, and both systolic and diastolic dysfunction. But in another study, undiagnosed heart failure was detected in 28% of patients with diabetes only during cardiac screening. So we might be missing a lot, especially among those with diabetes and heart failure with preserved ejection fraction. So heart failure is an early and forgotten complication of persons with type 2 diabetes. So when we choose treatment for heart failure for those individuals with diabetes, perhaps you have to get those with evidence that it can actually improve or prevent heart failure. In this slide, you can see that the different SGLT2 inhibitors based on different cardiovascular outcome trials would have greater efficacy in preventing cardiovascular events, hospitalization for heart failure, and all-cause mortality, regardless of the A1C levels compared to the DPP4 inhibitors. And here you can see those on dapagliflozin versus placebo. Dapagliflozin patients are those in the non-dotted lines, this one and this one, the red and the blue lines. And the dotted lines would be those on placebo. And you can see that for hospitalization for heart failure and cardiovascular death, it's much lower among those who are on dapagliflozin. Okay. So among SGLT2 inhibitors, only DAPA showed evidence in providing reduction in the risk of new or worsening heart failure among persons with diabetes by 27%. Now, if dapagliflozin can prevent heart failure, can it actually be used to treat heart failure? Here, actually, it was the European Society of Cardiology that declared this first, no, over the American Diabetes Association. They actually said that SGLT2 inhibitors should be part of treatment among those with heart failure. But of course, this is backed up by different randomized controlled trials. Yeah, it is a class 1A recommendation and a first-line therapy for the treatment of heart failure across a range of left ventricular ejection fraction that's low. And this there's a benefit that is consistent, and it also significantly reduced the risk of cardiovascular death. And this is backed up by the DAPA heart failure study. And again, this included persons without diabetes. 55% of these individuals did not have any diabetes. 45% had diabetes. And this is dapagliflozin versus placebo. And DAPA was well tolerated among patients with and without type 2 diabetes. And there was a significant reduction in the composite of cardiovascular death or worsening of heart failure, and it was at 26%. That was the relative risk reduction in total. Cardiovascular death decreased by 18%, and hospitalization for heart failure was about 30%. This is the reason why it is a class 1A recommendation for those patients with heart failure with reduced ejection fraction. Okay, let's move on. here. So based on this, the set of slides I showed earlier for the primary composite endpoint for those with type 2 diabetes, cardiovascular deaths or hospitalization for heart failure, it decreased by 25%. And for all patients, regardless of the diabetes status, it was 26%. Worsening of heart failure also decreased significantly, cardiovascular death and all-cause mortality. So these are the different randomized controlled trials for all of these outcomes. For you have your type 2 diabetes from the DECLARE study, and DAPA-CKD for those with chronic kidney disease. And the slides show that there was a decrease. There was a 31% relative risk reduction for all-cause death. And for heart failure, from the DAPA-HF, cardiovascular death was decreased by 18%, and all-cause death but at 17%. So you have your treatment goals here with your dapagliflozin with metformin. You have your glycemic lowering efficacy, 2.1%, weight reduction at 2.9 kilos. There's a 47% reduction in the risk of new or worsening nephropathy and 27% reduction in the risk of new or worsening heart failure. So now, how do we actually start SGLT2 inhibitors to our patients? Remember that the EGFR cutoff would be 20. Creatinine clearance should be at least 20. So for those individuals who have a history of recurrent UTI, you should be able to counsel them on good genitourinary hygiene. And you have to address all of these problems first before you even start them on SGLT2 inhibitors. And you have to monitor these patients closely for UTI, especially for those with the risk of genitourinary infections. And for the other individuals on NSAIDs, etc., of course, you have to monitor their GFR regularly. Always reintroduce SGLT2 inhibitors for those individuals with whom you stopped this drug, especially for those who underwent surgery, because ideally you should be temporarily discontinuing this drug for those who have acute illness or infection, or those who will be undergoing surgery. But once they're more stable on outpatient basis, you can reintroduce the SGLT2 inhibitor. Going back to Sander, our patient whose A1C was 8.5%, dyslipidemic, albuminuric, normal GFR. After 6 months, we can see that his A1C declined by 6.9%, BMI from 30 to 28 kilos, UACR improved to 34 from 250. Of course, we have to address dyslipidemia, and for Sander, it was rosuvastatin that was given to him, so the LDL is now at 1.9 or 72 milligrams per deciliter. Perhaps well, we are at goal for that. Sorry for that. Now, in summary, diabetes is a multifaceted disease, and heart failure and CKD are the first and most common complications of type 2 diabetes. The new ADA guideline focuses on 3 treatment goals: glycemic control, weight management, and cardiorenal risk reduction. Dapagliflozin provides superior glycemic control compared to the DPP-4 inhibitors. Glycemic control is not enough to control risk of developing complications such as CKD and heart failure. And so far, only dapagliflozin among all SGLT2 inhibitors give us the evidence in reducing the new and worsening heart failure and nephropathy in patients with diabetes, alongside with a superior A1C reduction. And that is my last slide, and I can now entertain questions.
Thank you, Dr. Fohas, for that comprehensive talk. We now have 511 watching and attending through Zoom, and I think 214 through Facebook Live, the UP Webinars 2023. We don't have the stats in the UP live stream. At this point, we'd like to thank our sponsor, AstraZeneca. Thank you very much. And the floor is now open for questions from the audience. Please type in your questions in the Q&A box in the lower edge of the Zoom screen or in the comment section for viewers of Facebook Live and UP Manila live stream. Okay, I can see 3 questions in our Q&A box. Let's start with the first question. For a patient who's taking DM2 maintenance medication, is there a way to purchase in bulk? So we're talking about purchasing in order to save money. Pwede ba direct sa manufacturer instead sa retail pharmacy? I'm taking the same medications.
Very good question. Actually, common yan na naririnig ko sa mga pasyente, no? But I'm not from AstraZeneca, but from what I know, it's bawal. The professional sales representative is not allowed to interact with patients. So everything has to go through a third party. It has to be a drugstore or a distributor. Bulk? Bulk, pwede naman mag-bulk. Pero usually, pag gagamit ka ng senior, usually 30 days lang ang nai-issue, right? Unless you are a seafarer or you're going overseas. But you have to show the drugstore your ticket. I think because that's what happens Mercury Drug from my experience. You have to show them that you have the ticket and when you're coming back so that they can issue the number of medications based on your, if you want to use your senior citizen ID or your PWD ID.
Okay, thank you for that. Just to clarify, is there a specific HbA1c cutoff wherein we could start DAPA plus metformin right away, or the HbA1c level doesn't matter as long as it reaches the criteria for DM, which is 6.5%?
Yeah, very good question. Kasi remember that you have your, when I showed you the guideline earlier, the algorithm, you have your multiple risk factor patients. So depends on your A1C, your target, no? Kasi remember, I showed nga kanina na whether or not diabetic, for as long as may albuminuria, you can actually start dapagliflozin basta meron siyang risk factors, multiple risk factors, and for heart failure, non-diabetics pwede din bigyan. So as for the A1C, for whether or not, depende yan sa inyo. So we are just talking about the dapagliflozin part. For the metformin part, it really is up to you with regard to the weight loss, your target weight loss. And it's not just the A1C, the reduction that we are after. Again, the basis is not just the A1C, it's the risk factors that your patients have.
Oh, okay. That helps. If the BMI is normal and or the patient is normotensive, is it still advisable to prescribe DAPA plus metformin?
Yeah, very good question, no? Galing. May study niyan. So it's actually more of the dapagliflozin. Metformin, you don't in a lot of cases kasi, even if the patient is lean, no, they might have some form of insulin resistance. And again, metformin is an insulin sensitizer. Based on studies, so the dapagliflozin with metformin, they had a study for this, ang nababawasan po ay visceral fat. So it's not, meron siyang plateauing effect when it comes to just the weight, but what we are after is decreasing the visceral fat. So it is safe even among those individuals who are within the normal or the target BMI. So you expect them not to really, yun nga yung problema, yung iba akala nila kailangan pa nila mag-further weight loss, no? But nabawasan na yung visceral fat nila. Merong certain target, yun ang nagta-target ng dapagliflozin with metformin. So it's still safe for those with normal BMI.
Okay, there's a question here also related to being overweight. SGLT2 are used for patients with type 2 diabetes to lower blood sugar. Can SGLT2 be used with patients undiagnosed with DM but are obese? just to lose weight?
Just to lose weight, as you saw earlier versus placebo, they just lose about 3.3 kilos. So there should be other means, like if you are still not within target, if you lose 3.3 kilos, baka kulang ang SGLT2 inhibitor.
Is it okay if patient 58 explore lap DM2 taking metformin long term and what's this?
Entresto.
Oh,
Usually kasi yung may entresto, may heart failure yun. And dapagliflozin actually is given to patients with heart failure, with or without type 2 diabetes. Now, taking metformin, okay naman, depende sa doctor nyo yung EGFR kasi ng pasyente. Also, the cutoff is 20. For as long as the GFR cutoff is 20, within 20 and above, okay lang po yun. Explore lap, I don't know what the significance of that is, but for as long as my heart failure and naka-interest, okay lang naman na may dapagliflozin and type 2 diabetes.
all right, let's move forward. Can metformin helps with the fatty liver? Help with the fatty liver.
So metformin, based on studies, meron naman siyang effect because it's an insulin sensitizer. It decreases hepatic glucose output. But a better question perhaps would be, can dapagliflozin help, or can SGLT2 inhibitors help for fatty liver? The answer is yes. There have been studies that I mentioned earlier that SGLT2 inhibitors can actually decrease visceral fat, and kasama yung fatty liver sa visceral fat. And one of those would be dapagliflozin. Yes, it can help for fatty liver.
What if the patient doesn't have DM yet, or you just diagnose the patient with fatty liver?
Ay, hindi siya indicated. Kasi, yeah, kasi wala siyang study na directly linking fatty liver. But for patients with diabetes who have fatty liver, which is so common, pwede siya.
Okay, so next question. Doc, what about those who have glycosuria but have normal blood glucose level checked with glucometer?
Yan, doon. Kasi we never use glucosuria as a diagnosis for type 2 diabetes. Usually, patients can have glucosuria if they're taking SGLT2 inhibitors, no? You have to have yourselves checked with OGTT or fasting blood sugar or A1C if you have diabetes. So, normal blood glucose used with a glucose meter is not that sensitive. So you have to go through the blood exams talaga and not just capillary blood glucose.
All right. So this is the first person who has Catherine Hora. Thanks for watching and attending. How about patients with PCOS? Can you give that?
Yeah, oo naman. PCOS, it helps. Although it's not in the guideline, no, it is actually used to treat individuals with polycystic ovary syndrome. However, for those who have PCOS, who have been diagnosed with type 2 diabetes, yes, you may give dapagliflozin with metformin off-label use kung gagamitin mo siya for weight loss for PCOS. If there's anything, it's metformin that is in the guideline for PCOS together with the other hormonal therapies.
Okay, ito medyo siguro in denial pa, no? So ayaw mag-treat. Can you get rid of type 2 just diet or lose weight?
Meron naman kasing type 2 diabetes in remission. No, so you can be diagnosed with type 2 diabetes and then control it dahil magaling ka. At saka maaga kang na-diagnose, no? Halimbawa, na sa OGTT mo, elevated lang siya. Tapos, and that is because of insulin resistance. You know, yung overweight or obese lang yung cause ng inyong type 2 diabetes. So, yes, pwede siyang mangyari when you lose weight and when you do the strict diet and exercise. However, remember that you have been diagnosed with type 2 diabetes. It will not disappear from the diagnosis. If you have been diagnosed with diabetes, it will be there. The doctor will just say type 2 diabetes in remission, which means that you have been off all your medications for diabetes for about a year and you have maintained your A1C and your FBS or OGTT within normal.
So, you heard it. You heard the doctor. Next question. Ang insulin po ba kasama ng pag-inom ng oral meds para sa diabetes ay nakakatulong sa pagpapababa ng HbA1c level?
Oo naman. Actually, hindi lang yun. With the insulin plus oral anti-hyperglycemic meds, it helps to decrease your it either decreases the insulin shots or decreases the oral anti-hyperglycemic medication. So, depende po yun sa doktor ninyo, doon sa need ninyo. Halimbawa, yung pasyente, kay sobrang nangayayat dahil sa tagal ng diabetes. So, kailangan may insulin po siya. Tapos, mamimili lang po sa mga oral anti-hyperglycemic agents na kung ano po doon yung pwedeng mag-gain ng weight, yung pasyente. So, unti-unti pong binabawasan yung insulin at kasi yung iba, mas nakakaganda sila sa kanila yung oral medications kasi mas nakakatipid. Lalo na kung masyadong mataas at first yung insulin dose, no? Pero unti-unting binabawasan yung insulin. Yung iba naman, mas nakakatipid sa 1 shot of insulin a day. So, depende po yon sa pasyente. Hindi po kasi dekahon ang pag-treat ng diabetes. Depende po sa risk factors ng pasyente. Depende sa ibang kondisyon. Halimbawa sa creatinine clearance, sa kidneys, ang pinaka-safe po doon sa may renal failure ay insulin. So, yung iba, hindi siya masyado maka-afford, pwedeng oral anti-hyperglycemic agent na safe din sa kidney. So, iba-iba po yung mga pasyente.
Okay, let's have a question from FB. Hello, can the combi of metformin and Jardiance duo have negative effect to the eGFR? Example, 39 from FB.
Anong 39? Ano yung 39?
eGFR.
GFR. Okay naman yung 39 na GFR. Kasi yung jar...
Yeah,
iba yung brand na nakakainis. SGLT2 inhibitor din siya. SGLT2 inhibitor din siya. So, it can help also with the improvement of the kidney function. But just watch out for the other parameters that can actually increase increase the risk for renal failure. Yes. Saka yung metformin dose, no? Kasi may metformin yung sinasabi din niya. Depende sa ilang milligrams po yung ni-recommend. Pag yung GFR mga 39, usually careful tayo sa metformin hanggang 500 milligrams lang. Okay?
Okay, in all your talks, laging may question na ganito eh. But, from FB, good day, Dr. Fojas. May I know your stand on Ozempic injection? Thank you.
Anong stand? It's really just for patients with diabetes and it's not available right now. Naubusan ng Pilipinas.
Talks mo to.
Yeah,
Kailangan
it's
talaga
really...
nilang kuhanan yung opinion mo regarding...
Yeah,
Okay.
it's indicated for persons with diabetes who are overweight or obese, and it's the problem is right now there's an undersupply for patients with that. So there are other injectables for diabetes, but they can be there are other GLP-1 receptor agonists that can be prescribed, but daily po yung injection, or meron din isang once weekly.
Once weekly. Okay, next question. Can we give SGLT2 inhibitors to patients with history of diabetic ketoacidosis? Since SGLT2 may cause euglycemic ketoacidosis. Thank you po.
You have to be careful pag nagka-history na ng euglycemic ketoacidosis, no? Kasi ang problema nito, yung iba kasi underdiagnosed, akala may type 2 diabetes when in fact type 1. So we have to be careful with these individuals. Also, may iba kasing pasyente naka-keto diet, hindi mo pwedeng bigyan ng SGLT2 inhibitors. Ito yung mga pasyenteng pwedeng mag-euglycemic ketoacidosis, no? Pwedeng mag-renal failure sila dahil dito. So you have to be careful. Question is, can you reintroduce SGLT2? You have to establish as to why these individuals developed euglycemic DKA. So, yun ang problema doon. So, baka this is not indicated for that particular patient.
Okay, you really have to consult with your doctor for these things. Okay. Is there a relationship of using metformin or patient diagnosed with PCOS po?
Oo, meron. Relationship of there is indicative relationship. Buti pa siya.
May hugot yung si Madam.
Hindi. Yeah, okay, yung metformin is indicated for patients with PCOS. Sometimes we give that lang instead of giving the oral contraception or the pills, no, to these patients. And sometimes just with metformin alone, nare-regulate ang menses po nila. Yes, there is an indication.
Okay, what's the pregnancy risk nito? Category, risk category for pregnant patients.
You know what? We actually, for PCOS na nagbuntis, we actually can continue metformin till
Oh.
term.
But
Some,
still,
merong ano, ha? Meron, lalo na yung ibang PCOS na may GDM as well, na naging fertile because of metformin, we can continue that.
Okay.
May iba-ibang schools of thought. There, the guideline, hindi specific, iba-iba sila. Yung iba dinidiscontinue, pero so far, merong continuation, may guideline na gano'n.
Oh, okay. So, can pre-diabetics or those at high risk for diabetes take DAPA as prevention?
Hindi po siya study for pre-diabetics, but it was given to those who were not diagnosed with diabetes, but with albuminuria and the risk factors for, and 55 years old and above with other comorbidities, hypertension, etc. And those with heart failure, even if they are not diabetic. But as for a study with a direct outcome that will say that it will prevent onset of diabetes, we do not have that.
Oh, okay. So, no study yet. Next
Hindi siya
question.
prevention.
If pwede po ang Forxiga sa may heart diseases, hindi naman po kaya mag-hypoglycemia ang patient po?
We're saying patients with heart failure, wala naman pong hypoglycemia ang SGLT2 inhibitors in general, because what it does is that it just decreases the sugar pag tumataas siya sa renal threshold. So ibig sabihin, for as long as your blood sugar is within normal, it doesn't kick in. Wala siyang hypo.
Okay.
Pero Forxiga to ha, hindi yung may metformin. Again, Forxiga ang nangyari sa DAPA-HF.
Okay. So, next question. Good day, MDs and UPCM. When to stop taking metformin after normalized HbA1c after 1 month? Can it be halted by client?
Ang hirap ng
Thank
tanong
you.
na yan. Ang hirap ng tanong, decision yan ng doctor nyo. How trustworthy are you? Kasi when to stop after normalized A1C after 1 month? May baka kasi nag-normal ang A1C nyo because of the metformin. So, kung minsan, we just wait until we can taper down the metformin if it's, let's say, in 1 gram and then taper down to 750. And let's see in 3 months' time if your A1C has been maintained within normal. And it's 1 month is too early to determine the A1C.
So, we have not anonymous again. Who braved the question and answer? Hi, Doc. How long will the patient take Forxiga?
Depends. 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 The earlier that you give it for those with the risk factors and for prevention of complications, the better. As for how long, depends on the risk factors, and for as long as the patient improves, yes, continue it.
Okay, I think, Michaela, we have already answered your metformin to lose weight a while ago. So, and next question. For patients diagnosed with PCOS, polycystic ovarian syndrome, is it safe to take metformin for a long time?
If the indication is just PCOS, it stays with you unless magmenopause ka na, no? So, it's safe for as long as you're within the reproductive age group, and then it's until your doctor tells you to stop it. Let's say, gumanda na yung ovulation mo. Kasi sometimes it happens. Ang nag-i-improve na sobra, you can discontinue it. But safety, yes, it can be taken for a long time. It has been studied also for a long time, especially among those with type 2 diabetes.
Okay, next question. How long will it take for DapaMed to take its full effect in lowering blood glucose?
You saw in the slide that I showed you, the A1C reduction, ang pinaka-optimal time would be within 12 weeks, no? So, 12 to 24 weeks, dumaganda na yung sugar nila. So, sometimes in 2 weeks time, bumababa na yung FBS and OGTT.
Okay. So, we answered the metformin, 100% safe for mother already. And then another question, SGLT2 are used for patients with type 2 diabetes to lower blood glucose. Can SGLT2 be used with patients undiagnosed with DM but are... Oh, all right. We have already answered this. Sinulat niya ulit, sorry. But it got longer kasi I thought what was a new. Okay, dun. I think we have already answered the question pa. Okay, may humahabol pa. Wait. What preventive measures need to do to avoid leading DM to renal failure? Leading DM to renal failure.
Okay, so preventive measures. Definitely fix the blood glucose, fix the hypertension, and fix the dyslipidemia. All those three, you have to fix, and with not just medication, but also with proper dietary restriction and exercises. And among our patients, it still works, no? Yung decreasing the protein intake from animal meat products, it actually helps, like decrease the beef and pork and decrease the uric acid levels in these patients. But of course, again, hypertension, control hypertension to decrease the albuminuria. It's not just the diabetes that can cause albuminuria, it's also the hypertension.
Okay, next question. Among patients with amputation risk, does DAPA decrease the risk?
Yeah. Doon sa, based on studies, it does not increase the risk for amputation. The reason why parang mataas doon sa canagliflozin is because these individuals that were included in the study were already at high risk for atherosclerotic cardiovascular disease, if you saw the Canvas trial earlier. So these are the individuals sa high risk. So hindi agad nila na-screen earlier, tapos later on, nakita nila na ito yung nagkakaroon ng leading to amputation. So, DAPA does not do that.
I have a question with regards to patients with retinopathy. Can it help?
Wala siyang studies na ganun. Perhaps indirectly because of the glucose control. And the anti-inflammatory properties of metformin. Actually, come to think of it, alam mo, dapat magka-study tayo ng ganyan eh. Kasi usually, pag nag-i-improve yung albuminuria, nag-i-improve din yung risk factors for retinopathy.
Oh, yeah. Going to be a good study for the Okay. How often should the patient follow up with his or her doctor?
Usually, we ask our patients to follow up in 3 months. Yun yung optimal time because that's how we can take a look at the A1C, and at least from baseline up to the 3rd month, makikita mo yung lipid profile, makikita mo yung not just the A1C, UACR if it is improving also. And you can see the patient's adherence to your medication dun pa lang. So every 3 months at least, until such a time na parang, uy, ang galing, kuha niya na. Tapos na-maintain. Another reason why we want our patients to follow up a little bit earlier is because we want to taper their medications down. Kasi at first, usually, kung marami kaming binibigay na gamot, kasi tina-target namin yung pangit na laboratorio, pangit na kondisyon ng pasyente. But in time kasi nag-i-improve sila. So dahan-dahan nating binabawasan ng mga gamot. Kaya gusto din natin mag-follow para makatipid ang pasyente.
Okay, last question from FB. What are the signs and symptoms that could prompt emergency for patients with diabetes as well as with renal damage due to prolonged on and off hypertension?
Emergency, yung poorly controlled blood pressure, kailangan sana ma-monitor yan. Yung sugar na persistently above 250, lalo na kung whether fasting or non-fasting, kailangan yon. Tapos yung iba kasi, kung naaamoy niyo yung breath, merong hyperketotic breath, parang amoy alcohol. So that's a sign of diabetic ketoacidosis. Kung also persistently parang nababawasan ang urine output or sudden weight loss, tapos nawawala sa sarili, pwede po yung senyales na diabetic emergency. Pero ang mahirap po dyan yung sa ating mga older individuals, hindi masyadong nakakainom ng tubig kasi hindi sila masyadong nauuhaw. Mas kailangan tutukan itong mga senior citizens natin na poorly controlled diabetes kasi mas high risk sila na ma-ICU.
All right, that was our last question. Thank you for all the questions from the audience, and thank you, Dr. Fojas, for enlightening us with your answers. Okay, so
Thank you rin.
thank you. Ang daming tanong today. So, thank you to our speaker for taking time out of her busy schedule and sharing her expertise with us today. As a sign of our gratitude, we would like to present this certificate of appreciation to Dr. Mia C. Fojas. Thank you very much, Dr. Fojas.
Thank you rin. Thank you, AstraZeneca, UP College of Medicine, Class 99, and Elizel Claveria. Sorry, nagunsad talaga. Elizel for being my moderator for this session. Thank you everyone who attended this webinar also.
Okay, may we request our audience to please stay for some reminders. We would like to thank the UP College of Medicine, the Postgraduate Institute of Medicine, the UP Medical Alumni Society, and the UP Manila Information Management Service for their support of this webinar series. And again, thank you to our sponsor, AstraZeneca. We are inviting everyone to watch our next webinar on November 16th, 2023, Thursday, same time at 12 to 1 p.m., entitled Standard of Care and Legal Duties of Physicians in Telemedicine. Our speaker will be Dr. Lee Edson P. Yarsha. Dr. Yarsha is also a lawyer and is currently a senior lecturer at the UP College of Law and lecturer at the UP College of Medicine. He is a legal expert for the United Nations Joint Program for Human Rights in the Philippines. For those who want to get a certificate of attendance, kindly answer the evaluation form and post test within the next hour. You can access the link through the QR code posted on the slide or use the URL posted in the chat box. Thank you very much to all our attendees. Have a good day.